Hello, good morning, good afternoon, good evening. My name is Sylvain Gaillard. I'm the head of corporate medical marketing of Sigvaris Group. And as such, I'm very pleased to welcome you to the third and unfortunately last global MOH meeting of 2020. And we will have presentations from different speakers worldwide about the topic lymphatic pathologies, therapeutic strategies, and the consideration of regional aspects. It's my great pleasure to introduce our host of today, our moderator of today, Frank Aviles. And Frank is a passionate wound care clinician with over 30 years of experience in multiple certifications in wound care and also in the lymphedema area. Currently, he's the wound care service line director for Natchitoches Regional Medical Center in Louisiana, consultant for LSCH Group LTAC division and owner of CRTS. Frank holds active roles in various associations, has lectures in both areas of interest nationally and internationally. He has been contributing as author on various books, published articles, has a column in a national magazine, and is creator, host, moderator of the virtual wound rounds. His goal is to educate clinicians and patients on not only doing what's right, but knowing what right is. This is my big pleasure to hand over to you, Frank, for the introduction of the expert panelists and also the first speaker of this event.
Well, thank you, Sylvain. I do want to, first of all, thank Sigvaris Group and you and Mahmoud for having me here. I'm in awe to be in the level of clinicians that we have for today. I am passionate about what we do because clinicians poorly understand these conditions and they have a problem recognizing it and also how to treat it. So this is a life chance for me to be moderating this, which we're going to be talking about lymphatic pathologies. And I do want to thank the audience for attending this. Okay. I also want to give you some housekeeping rules before we get started. So this session will be recorded. So if you want to watch it later or you have others that would like to watch it, our expert panel will answer questions. Okay, so at the bottom of your screen, you see the Q&A section. If you write down your questions, we'll have time to ask them. Okay, each expert panel will be allotted time for the presentation, and then we will have questions afterwards. Okay, so now I do want to welcome our expert panel. So our expert panel comes from all over the world. So we have, first of all, Dr. Pinar Borman. She brings a wealth of information as a subject matter expert. She graduated in '92 from Ankara University Medical Facility. In 1998, she specialized in physical medicine and rehab. In 1993 and then in 2012, she became an associate professor and then a professor. In 2013, I'm happy to say she's certified in lymphedema therapy from Norton School of Lymphatic Therapy. And since 2014, she's a founder and chair of the Anatolian Lymphedema Association, which she's coming from Turkey. Her interest areas are lymphedema and geriatric rehabilitation, along with pain medicine. She belongs to numerous associations, and she's written and co-authored over 200 articles on this subject. So welcome, Dr. Borman.
Welcome.
So we also have Andrea Mangion. Andrea does a magnificent job educating others, and she's so passionate about her work. She's a lymphedema physiotherapist and an honorary lecturer at Macquarie University. She is a Castley Smith International Lymphedema trainer and has been involved in running the Australasian Lymphology Association accrediting courses for the last 9 years. Andrea is also the founder of Help Online, which is Australia's first-line portal of patient information on the management of lymphedema. So, Andrea, thank you for being part of this.
Thank you so much, Frank.
And now let's go ahead and get started. I do want to introduce you our first speaker. With us today, we have Dr. Ningfei Liu, and she is a professor of plastic surgery. She holds a PhD as well. She's a former president of the ISL. She's the director of the Lymphology Center. She's the Department of Plastic Surgery and Reconstructive Surgery of Shanghai Ninth People's Hospital. She's also with Shanghai Yang Tong University School of Medicine, She's the head of the Lymphedema Group, Chinese Society of Plastic Surgery. And I do have to say, her interests are in medical and surgical treatment of lymphedema with multimodal diagnosing. Now, Dr. Liu, thank you for being here, and we're going to turn it over to you.
Hello.
So let's go ahead and cue up Dr. Liu's presentation.
My first?
Yes, ma'am.
Okay. Good evening or good afternoon or good night, everybody. I'm happy to join this meeting in the topic of lymphatic pathology. I think this is a very good subject because lymphedema is caused by lymphatic system dyspressure, dysfunction, or damage. The ideal treatment is the targeted therapy to the lymphatic malformation or the defect.
Okay.
I have some problem with the computer.
So let's see if we can
To move on my slide.
There we are. Dr. Liu, it's working.
I cannot move on my slide.
Doctor, you need to click any place on my screen and start controlling my screen. Doctor, using your mouse, start controlling my screen. Yes, please.
Yes, I use it. The computer says that somebody used my screen, so I cannot control it. I don't know why.
Okay, doctor, I will play yours. Doctor, you have your presentation open? Doctor, I will share the screen and I will move for you the slide when you tell me next, okay? I will share it for you.
See it now? I restart it. Can you see it now, my slide?
No, not yet, doctor. You have first to click on share screen inside Zoom. Click on share screen.
Can you see now?
Not yet, doctor. You have to click on share screen inside Zoom. Share is. Doctor, I will share for you the presentation and I will play it for you. You just tell me next to move forward, okay?
Mm-hmm. Can you see it now?
Okay, doctor, please start.
You can see now.
I am sharing your screen. Just tell me next, doctor, so I can move for you forward to next page.
Can I continue to my presentation now?
Yes, doctor. Go ahead and get started.
Okay. The lymphatic pathology in the primary lymphedema, because primary lymphedema, the clinic symptoms are diverse. It can happen in the arm, in the leg, or in the face. The pathogenesis is complicated underlying these symptoms. It can happen in the lymphatic vessels or lymph nodes. It can be anatomical problem or the functional problem. We use the MRI imaging, lymphangiography. We can see the different type of lymphatic malformations in the primary lymphedema. It can be the malformation in the superficial lymphatic systems, and it can also happen in the deep lymphatic systems. The lymph nodes too can be the primary cause of primary lymphedema. It can be the hyperpressure of the inguinal lymph nodes, or the problem with the structure deformity of the lymph nodes and the vascularized lymph nodes and not developed inguinal lymph nodes. So both lymphatic vessels and lymph nodes can be the problem of the primary lymphedema. So according to our results tested on the 500 of patients, we got the results that the lymphatic system pathology in the primary lymphedema can divide into 4 types. The lymph nodes affected only, or lymphatic affected only, or both lymphatic and the lymph nodes affected. The last type is lymphatic dysfunction. Now I show you some picture. As a matter of fact, the lymphatic malformations can happen in the different levels of the lymphatic system. It can happen in the initial lymphatics, or pre-collectors, or collectors. This is the picture of a primary lymphedema patient. We can see in his bilateral lower extremity, there are a lot of dilated lymphatic vessels, but the lymph nodes looks normal. This is another patient who has the KT syndrome. In his lymphangiograph, you can see on her left lower extremity, there are the obvious dilated, like a network, the abnormality of the lymphatic vessels, the superficial lymphatic system, and there is a big vein. But in the inguinal region, we cannot see the lymph nodes. So this patient has the lymphatic hyperpressure and the lymph nodes are pressure. This is a common disease of the primary lymphedema. We call it Miller's disease. This patient has the FLT4 mutation. On the ICG lymphogram, we see there are some lymphatics in the foot. It means that the lymphatic existed in his leg, but it cannot work well to transport the lymph flow. So this is the lymphatic dysfunction. This is another case of Mirror's disease. In the ICG lymphogram, we cannot see the lymph vessels. We took the skin biopsy to make the staining. There are no initial lymphatics can be identified in the skin. So this patient also has FLT4 mutation and also the mutation of VEGF-C. So the conclusion is this patient has the lymphatic up pressure. So the lymphatic malformations in primary lymphedema is complicated. At this moment, there's no targeted treatment for the malformation of lymphatic system in the primary lymphedema. So what happens of the lymphatic pathology in the secondary lymphedema? It can happen in the collecting lymph vessels or initial lymphatics or the lymph nodes. For example, the lymphatic dilatation, disruption, lymphorrhea, or it can happen in the leech and with the fibrosis of the lymph nodes or atrophy. It can also happen in the lymph vessels of the initial lymphatics or the collecting lymphatic vessels of the sclerosis or obliteration. Now I show you some picture. This is the MRI lymphoangiogram for the breast cancer related lymphedema. You see in this picture, there are dilated lymphatic collectors with disruption and with the leakage of the lymph flow. And this is after the regeneration of the damaged lymphatic vessels. So this happens in the secondary arm lymphedema. This picture shows that the secondary lymphedema, in the secondary lymphedema, the lymphatic vessels also can be badly damaged. You can see here in the lower leg, there are dilated lymphatic vessels with the disruption of the lymphatic vessels. In the thigh, you see extremely dilated lymphatic vessels. And this is the patient with the cervical cancer after the surgical treatment and the radiotherapy. So you see the lymph nodes without normal structure. Also, in the dermal initial lymphatics, if you took the skin biopsy, make the staining of the lymphatic vessels, you can see a lot of small muscle cells around these small vessels, no matter secondary or primary lymphedema. You can see the common damage to the initial lymphatic vessels. So this may be the reason of the treatment of lymphedema is so difficultly because the initial lymphatics are sclerosis, fibrous. So for the surgical treatment, for the physiological treatment, you can perform the lymphovenous shunt procedures or the vascularized lymph nodes transplantation or lymphatic transplantation. But you should make very carefully the selection of the patients. Before you do the surgery, you should make the image test to see if the lymphatic vessels are healthy, are patent. So this because if the lymphatic is damaged badly, the results are not good. This is example of the physiological surgical treatment. We use the supraclavicular lymph node flap transplanted in the patient's lower leg for the treatment of secondary lymphedema. But at the moment, we did not prove the regeneration of the lymphatic vessels with the recipient area. So we still need to collect more patients to see the results, to get the conclusion of this kind of procedure. But at this moment, most of the therapists, of lymphologists in the clinical work, we doing most of our work on the pathology of the lymphedematous tissues, not the lymphatic system. In this picture, you can see in the different stage of lymphedema. In the early stage, there are some water in the lower leg, but as the disease developed, there are more edema fluid in the subcutaneous tissues, and in the advanced stage, you see a lot of fibrosis and fat tissues deposition in the skin. So this is the most difficult work for us to do with these pathologies. What most clinical work doing is work on these overgrowth subcutaneous tissues, those fatty and fibrotic tissues. For the surgical treatment, you can do the liposuction and also the debulking surgery. But the results of debulking surgery is not good, considering of the leg you see here, and maybe there are some severe complications can happen. So now, most commonly used for the conservative treatment is CDT. CDT treatment is to cause the lymphedema to regress to a clinical edema-free stage or decrease the stage of lymphedema. It does not mean that this disease can be treated. What the other treatment in our hospital or in our city is the far-infrared radiation therapy. It can reduce edema and inflammatory complications. The IPC can be used. It has a long history of the treatment, but it should be work under the instruction of the doctor or physician. Otherwise, the result is not good. This picture shows how MLD work. I think the other therapists can give you a good presentation. This picture just shows how it works, can stimulate the lymph nodes and the vessels to speed up the lymph flow. And the bandaging also, it's the same, it's universal used also in our hospital, in our center. The compression garments, too, we use different kind, and according to patients, the condition, we use different compression garments. But in some cases, it's difficult to treat patients with the suitable garments. This is an example for the children with this kind of the lymphedema. We have plenty of such cases. And this is another difficult cases with for the woman who has been operated for the pelvic lymphodissection, you see the abdomen is swelling so badly. What kind of bandage we can use during the treatment of the CDT? And after treatment, use such kind of garments. Yeah, but this is a big challenge for us for this kind of lymphedema in our clinic. This picture shows the 5 infrared radiation therapy. This is the specially designed device for the treatment of the lymphedema of the lower legs. This only for the treatment of chronic lymphedema of the extremity, for the arm or the leg. We can see this figure shows us that it can be reduced. It can reduce the inflammatory reaction complications. It have the very good results for this kind of inflammatory cases. IPC also in most of our clinic, we use it. We combine this treatment with the CDT or with the surgery as the other areas or countries. We think that the most important things is education in individual self-treatment, because lymphedema is a long time treatment for the whole lives of the patients. So every patient come to our clinic, we educate the patients how to do after the treatment in the hospital. So if the patient follow the instruction of the surgeons or the doctors, we can see the good results. So that's all my presentation.
Dr. Liu, thank you so much. That was a wonderful presentation. Love the imaging that you showed us. Let's go ahead and take a polling question. Can we put the polling question up?
Great. So the first poll question is, which of the following surgical methods would be an appropriate treatment option for secondary lymphedema in your point of view? The choices are lymph venous anastomosis, fat tissue transplantation, or split skin transplantation. Please tick one of the selected one, of the possibility answered.
While we wait for the poll, let me ask a question to their panel. Dr. Borman, so when you're looking at patients, which diagnostic method do you like for your patients? And does it matter if it's primary or secondary? Dr. Borman, let's go ahead and unmute. There you go.
Okay. In the last 2 decades, the management has been very increased and the awareness of lymphedema in Turkey has been very increased. We have several lymphedema units in Turkey, but majority of them are placed in big cities, in metropoles, in university hospitals or research hospitals. Our approach is like that. First of all, we take a detailed anamnesis and detailed physical examination. With the volumes, we make the calculation of the volumes by circumferential measurements. And then if the parameter, for example, we have an LDEX, we can use other measures to determine the volumes. And then We take the photographs of each patient and we give education in the first visit to the patient. What is lymphedema? What does she have to do? Skin care, other things, living daily activity modifications, and etc. And then we stage the patient according to circumferential or commonly with volume measurements. Stage 1, stage 2, or stage 0 for prevention, for example, for risk, for patients having risks for lymphedema. And then we plan, first of all, conservative treatments. Complex decongestive therapy is the most commonly used technique. We follow the guidelines of ISL and ILF and NLN. And we plan CDT for all the patients. We try whether she is advanced or he is advanced or mild lymphedema. But for prevention techniques, for example, for risk patients with risks, having risks after cancer surgeries, especially, we gave them pressure garments and we gave them self-management. We teach them self-management techniques and we follow them. But for stage 1 to 2 and for 3, we always, first of all, perform CDT. As Dr. Liu has shown, MLD, multi-layer bandages, exercises, and we teach all patients on these sessions self-management techniques that will continue during all his life and that she or he will need to perform. And we educate the patients' families also. And the other important point is the pediatric lymphedema patients. And we always work with multidisciplinary, as a multidisciplinary team for all lymphedema patients with surgeons, PTs, of course, lymphedema therapists, of course. There are the main professional group in the treatment with us. We work with collaboration, and pediatricians, gynecologists, breast surgeons, and psychologists, especially for pediatric lymphedema patients. You know, they need psychological support also, and nurses. Nurses are also very important for prevention of lymphedema and for also wound management and other complications of lymphedema. And after CDT, we call the patients for follow-ups by 3 to 6 months. And the outcome measures we use are circumferential measurements and especially volumes, the quality of life, and the functional disability. Because we, in every patient in our university and in our research center and in majority of the lymphedema centers in Turkey, we use quality of life instruments, functional instruments, and volume changes as outcome measures. And we call the patients for follow-up. And after this intensive period, we gave our patients, according to their lymphedema situation, their conditions, comorbid disease, and other things, we always give them pressure garments. According to type and the severity of their lymphedema, and we educate them, and sometimes we need to modify these pressure garments, for example, for elderly, for disabled patients, or for the ones who do not want to make self-bandages, or who cannot easily don on and don off the pressure garments. We use, in the last years especially, Velcro adaptive devices. These are very useful and very easy. And then we follow up. Sorry, is it too long?
Sorry to interrupt. The poll question is back on here. We're going to get back on that topic a little later, so just hold on. Andrea, I'll come back to you. And Dr. Corradino Campisi, thank you for joining us. So the result for sharing the question, 84% chose lymph, venous, and anastomosis. Now, I do have a question from the audience. Dr. Liu, one question came in. What are the contraindications of using the far infrared therapy and also the complications of any? So what kind of contraindications of using far infrared therapy for your lymphedema patients?
Contraindications, yeah, the acute infection.
Okay.
The patient after the cancer treatment, beyond the 5 years after the cancer treatment, if the patient is okay, so we can do this treatment. But yeah.
Okay, thank you. Andrea, now let's get back to you. What are your views on doing manual lymphatic drainage prior to surgery?
Yeah, now in regards to the literature on prevention of lymphedema with manual lymphatic drainage, I think there was a Cochrane review that looked at whether manual lymphatic drainage could prevent lymphedema. And as far as I recall, that particular publication said that it couldn't necessarily prevent lymphedema. And I would need to go back and double check that publication, but I think from reading it said that we can definitely look at using it as an early strategy. We know that that same publication did say that if we look at utilizing manual drainage early lymphedema versus late lymphedema, we know that we're going to get better flow through our lymphatic vessels in early lymphedema. So manual lymphatic drainage definitely is more effective in your stage 1 lymphedemas, for example, than your stage 3. And when we look at what happens within the lymphatic vessels, we know that from the work of, say, for example, Mahara and colleagues, where they show you the pathological changes that happen inside the lymphatic vessels, we know that in early lymphedema, the lymphatic vessels are more patent. So it makes sense that our lighter techniques are more effective in very early lymphedema compared to your more chronic lymphedema.
Thank you, Andrea. Appreciate it. Now, our next speaker is coming up, Dr. Corrado Campisi. I'm excited to be on the same panel with Dr. Campisi. He is well known for his surgery of the lymphatic pathologies and microsurgeries. He's phenomenal. He's received 2 masters, one in reconstructive microsurgery and the other in healthcare and pharmaceutical administration. He is a surgeon. He has been visiting at many institutions as a visiting professor, and he's also well published. So today with us, Dr. Campisi, thank you.
Thank you, and greetings from Italy to all the panelists and all the participants to this fantastic webinar. I am sharing my my screen in order to launch my presentation. Lymphatic surgery, lymphedema treatment, the Genoa-Italy protocol. I have no disclosures, and lymphedema surgery is really a matter of experience. And the Genoa school started in 1973, so many years ago. And nowadays there is a lot of confusion regarding the correct indication for surgery. There are many options: the ICG, green lymphography, the lymphoscintigraphy, magnetic resonance. But still there is a lot of confusion in the indication of surgery, especially regarding reconstructive procedures. ICG, so green dosing, has many options because in lymphedema patients, the depth of the tissue can minimize the resolution of the procedure. So it is very, could be also dangerous to perform choices and indications for surgery according only to ICG technique. I have to say that the reconstructive methods that we perform are based on the lymphatic venous shunts, and the surgery we perform for the lower limb is focused on the groin. For the upper limb, it is focused on the upper brachial region. And in one time, we can, with one single incision, we can repair both the superficial and deep lymphatic system. Here is a video showing the deep lymphatic pathways. Lymphatics in this stage are extremely dilated. So this is the best condition for lymphatic venous shunts, because there is a strong flow in the lymphatic vessels, and the lymphatic vessel is not damaged by the substitution of fibrotic tissue that can occlude the lumen of the lymphatic channel. The deep lymphatic pathways can be effectively repaired, so it is very important not to focus only on the superficial lymphatics. So the study of the preparatives planning is extremely important. You can see the ICG during surgery can show you the patency of the anastomose, and the anastomose is performed using different lymphatic channels in one vein, and we can perform different anastomose in one time. We have performed different studies on lymphoscintigraphy regarding the recommendation for the procedure, and we're seeing that in a lot of cases there is a damage of both the superficial and deep lymphatic system. Like in this image, that you can see that there is a shunt between the superficial and deep lymphatic system. In this lymphoscintigraphy, there is an impairment of the deep system in both lower limbs, as you can see also in this image. Or there are more complex cases in which you have an impairment of both the superficial and deep system of both lower limbs, like in this case. The lymphoscintigraphy can help also to study all the lymphatic pathways. So a total body lymphoscintigraphy can be useful also in primary cases in which could be also an impairment on the upper limbs and also in the abdomen and in the thorax as well. The other study we've done is enhancing the importance of the study of the deep lymphatic system. We have taken nearly 250 lymphoscintigraphies of primary and secondary lymphedemas, unilateral arm, leg, or bilateral of the legs, using the transport index. And we've seen that in the majority of cases, there was an impairment of both the deep and superficial system, up to 97.4% of cases. On the other hand, only superficial vessels were impaired, singularly only up to 12.8% of cases. So our algorithm in these cases is made to choose the best lymphatic microsurgical procedure according to the lymphoscintigraphic pattern. The pedicle selection is done using the ICG method and also the blue dye, because we've seen that there are cases in which pedicles are fluorescent and positive, but not blue dye positive, or vice versa. There is, as I said at the beginning, some instrumental confusion regarding proper indication, like in this case, in which you see a primary lymphedema. It seems that there are no good lymphatic channels for the anastomose, but then when you perform the small groin incision, you see lymph nodal structures that are behaving as an obstacle, so obstructing lymph nodes, and after the lymphatics reaching these nodes in perfect condition. So this is very important to choose the right method, because this surgery can be extremely helpful for the patient and also for his quality of life. Of course, the earlier treatment is the best, because in later stages there are fibrotic adipose substitution, and this makes the disease possibly also irreversible. We use the Campisi staging of 2009 that divides the stages in 3 and other substages A and B up to the stage 3, so with extreme elephantiasis with total disability. And our protocol is based on a phase 1 in which we perform a lot of physical treatment, so no surgery, and then the reconstructive surgery has its role, and then phase 3 in which we follow up the patient with the post-op care And eventually, if necessary, we suggest the patient liposuction, lymphocytic liposuction to remove the fibrotic tissue in advanced cases. We have adopted also the physical exercise in our center. You can see we have many machines, physical treatment added with active exercise. We are doing a project with Technogym, and this is something that is helping a lot of patients in their preparation to surgery and also after surgery as a lifestyle. And we have treated so far nearly 150 patients since last October, and we are extremely happy for the results, especially in preparation to surgery. And patients are sent back home with a specific program, also an exercise program, in which they can add also the physical treatments or home treatments that they can perform at home. Also, phytotherapy is extremely important. So natural products, we have shown that they have a possible synergic role in adding to lymphedema surgery, to physical treatment, to physical exercise. The surgery we perform is a multiple lymphatic venous anastomosis, so multiple vessels in one vein. And we use this technique as primary prevention. So, for example, patients that need to undergo lymph nodal clearance, for example, for breast cancer in the axilla, so at the same time of lymph nodal clearance or for melanoma or for other type of cancer, we use it at early diagnosis, sort of for secondary prevention, and also for tertiary prevention, using also liposuction after microsurgery. We use, as I said, blue dye and green indocyanine for the pedicle selection. And it shows, tells us which pedicles are in good function and can supply a good flow for the anastomos. And the best condition is to have lymphatics that are extremely dilated. So this is an example of lymphatic dissection. The lymphatic wall is not skeletized, so the vessels are in very good condition for the anastomos. And we perform this anastomos and in one side, the groin or brachial region, with an optimal flow, because the vein has no reflux. We can also, in some cases, repair the vein incompetence with external valvoplasty. And finally, the anastomos is very, very powerful. The same for the upper limb, the same concept in the brachial region. And we perform a very significant study for the surgical planning, also from the venous point of view. And in this case, for example, in this video, you can see the median nerve, the brachial artery, well, very deep in the upper limb, and the lymphatic channels, the deep lymphatic channels that are ready for the anastomos. The power of anastomos depends on the lymphatic function and also in the vein competence. These are two main factors for the success of this surgery. And we can check the patency intraoperatively. We can check the patency also later with post-op lymphoscintigraphy at 6 months, 1 year, or also more from the primary surgery. Multiple lymphatic venous anastomos can be performed in one single site using different veins. For example, in the saphenofemoral junction, that are there are many possible options that we can apply for the best lymphatic venous anastomos. We can repair all three levels. So the very superficial level, subdermal, we can repair the superficial deep level and the very deep level under the masseter fascia. So in one side we can repair the superficial and deep lymphatic system with a single incision between 3.5 to 4.5 incision in the groin or in the brachial region. So it's a single site surgery with a very low infection rate, and on average we use 15 vessels. There is no complaint for compression stockings if they're needed after surgery. And we have more than 5,000 patients treated with at least 5 to 20 years of follow-up. Here are some results. You can see before and after. I'm skipping a bit quickly, not to take too much time. Before and after primary and secondary lymphedemas. This is after physical treatment and lymphatic microsurgery. Very good results in primary lymphedemas like this one, in secondary like this one, or cases like this associated also with morbid obesity, in which good vessels can be found. So also in these cases, the reconstructive procedure have a role and can lead to nice results immediately after surgery, a few days after surgery. So when we should apply liposuction? The liposuction that we use is a preventive liposuction. The liposuction is a lymph vessel screening liposuction. We map the lymphatic system, we map the venous system, we perform liposuction after microsurgery, avoiding to damage the lymphatic collectors. For example, in cases like this that have a very good result after physical treatment and microsurgery, but still there is a difference in volume due to the deposition of the fibrotic and adipose tissue, like this one after cervical cancer treatment, a good result, but still not perfect. Or in this case, in a young guy after Hodgkin lymphoma treatment, radiotherapy, lymph nodal biopsy, a secondary lymphedema, a very good result after microsurgery, but still not perfect in our point of view, because fibrosis and adipose tissue still prone patients to infections. So it's not a standard no-look liposuction. We map the lymphatic system, we perform the incisions, very small incisions, according to the lymphatic mapping that we perform preoperatively together with the venous mapping as well, superficial venous mapping. We can perform a safe liposuction in the thigh. We can perform the same in the lower part of the leg, near the ankle, the foot as well. And we check the lymphatics before and after to see if there are any leakage from the fluorescent lymphography, and to check possible damage to the lymphatic system. So the main goal is to avoid lymphatic destruction. This was the patient of before. You can see before and after, a very good result. Other patient following secondary lymphedema for cervical cancer, before and after. Before and after as well as secondary lymphedema. This is a post-traumatic lymphedema. This is after melanoma treatment. This is a primary lymphedema on the right lower leg. Secondary one, a primary lymphedema associated with chronic vein insufficiency. Secondary lymphedema, another secondary lymphedema following melanoma treatment, and some other cases of upper limb lymphedema following breast cancer treatment. And the results that can be achieved are extremely significant, especially in terms of long-term outcome, because the main goal is to give the patient a better and constant quality of life. We are a multidisciplinary team with many professionals inside our teams, not only surgeons. Every kind of people that are present in our clinic are extremely fundamental for the success in this process. We are very active, at least before COVID came, with a lot of courses, especially also in cadaver dissection. This is one that we have organized with SNT and Groningen University in Holland, and to help also people to apply the knowledge and the possibility to establish a lymphatic surgical center in their city to help patients that need this kind of surgery, because there is a paucity of people that perform lymphatic surgery around the world. I will be organizing the International Society of Lymphology Congress in Italy, in Turin, in 2023. And we have been celebrating the World Lymphedema Day since 2019, 6th of March. We're done also this year, and but there was COVID, so we were blocked on this, and we will do next year with an online webinar and seminar. This is one of our advocates from Canada, Steve Kellan. We have many patients coming from all over the world, and we keep working hard because lymphedema is a chronic disease, and the soonest is diagnosed, the better is diagnosed, the better and the best is can be achieved for the patient. Thank you for your attention.
Thank you, Dr. Campisi. Because of time, we're going to just take audience questions first, and then we'll do the polling afterwards. One of the questions came in early on, and the question was, what is the success of your venous anastomosis surgery with chronic lymphedema?
We have a very good success rate. Of course, this depends on the staging of the lymphedema. We have a minimum constant reduction on lymphedema that goes from, in the more advanced cases, from 30-35% to up to 80-85% of reduction. Very rare cases, we can go also up to more than 94-95% reduction of the excess volume. It depends also if there is fibrotic tissue, there is adipose tissue. In these cases, we need also liposuction to gain this result. And in terms of post-operative treatment, our goal is to leave the patient, as free as possible. So, I mean, the main goal is really to give a patient a better and constant quality of life.
Dr. Campisi, it was great to actually see the surgical, what you do on your end, because when we treat with complete or complex decongestive therapy, you know, we're kind of just telling the students what we're doing, but to visualize it is phenomenal. Another question that came in is, what is the best microscope to do your surgeries?
There are different. The one that we use is I mean, we are used with DICE technology, but also Leica technology is very good. There is one from Japan that is very good as well. That is Mitaka. So there are many options. The microscope that we use helps us to have a magnification up to 50 magnification. So I mean, we need that to see the lymphatic wall, lymphatic lumen, and to perform the best anastomosis. Of course, we also use very small suture devices. We go from 8.0 up to 12.0 sutures as well. So it depends on the case, it depends on what we need to do, but regarding the microscopy, the one that we use, that we're more used to, is the DICE instruments.
Okay. You mentioned a couple surgeries, the LVA and also the fibro. Is the post-op care any different between the two?
Yes, because after lymphatic microsurgery, the patient lay on bed for 2-3 days. Over limb. Liposuction, the patient works the same day of the surgery. So the recovery after liposuction is a little bit faster at the beginning rather than the microsurgery. The fact is that the microsurgical fraction is something that we use as option only once. We don't perform many trials. We do microsurgery once, and we reconstruct the best we can do according to this. Liposuction is something that we will perform later on a non-pitting edema. So we don't want lymphatic stages in the leg or in the upper limb to perform liposuction, because the indication is a non-pitting edema. So in those areas, especially in the fibrotic areas, we perform liposuction with.
Okay. Dr. Campisi, I know that you have a busy day and you must run. So if there's no other questions, we thank you for taking part of this. And I do want to also introduce the man that's right behind you, which is Dr. Corradino Campisi. In my opinion, he's a pioneer in the lymphedema field when it comes to surgery and microsurgery. He does have, he's authored over 500 articles, scientific articles, and he's involved in numerous journals. So Dr. Campisi, thank you for joining us as well.
Say bye to you. I leave the laptop here with my dad. My dad will stay with you. And I go to see patients because we are in the clinic now. Thank you for everything. And this is a magnificent webinar. Thank you for the invitation. And my dad will stay with my laptop to it. Okay.
Thank you, Dr. Campisi. Have a great day.
Right.
Right. Now, let's go ahead and take the poll question.
Okay, we have the second poll question is, what is your treatment of choice for patients with peripheral lymphedema? The first choice is complex decongestive treatment, or B, lymphatic surgery and macrosurgery, or C, A and B together based on the individual condition and stage. Please make your choice.
Thank you for your kind invitation, and my best to all of you. I prepared multiple choice questions for young people participating to this webinar. Very interesting and innovative webinar you organized. And I think that there are some basic concept to consider. The first is that primary and secondary obstructive lymphedema, both of these two categories, poorly responding to proper conservative treatment are the right indication for lymphatic microsurgery. Then the problem is to have the possibility to offer to the patients this proper physiotherapy, conservative treatment. And as you well know, this aspect is very difficult often to organize according to the different social conditions and reality, real organization, sanitary organization in each country all over the world. That's why we have to think about the best comprehensive treatment according to the different regional conditions, social conditions. And another important question I would like to underline is that which is, I appreciate very much the presentation and the introduction by my friend Professor Ningfei Liu. And if we consider the diagnostic assessment of the patient, which is the peculiar investigative procedure with basic role for the indication of lymphatic microsurgery. The venous color Doppler, partially. The magnetic resonance lymphangiography, partially. The superficial lymphoscintigraphy, partially. I think, according to our long experience, that the best investigative procedure for the indication of lymphatic microsurgery is lymphoscintigraphy up to date, superficial not only, and deep. Superficial and deep, with the transport index calculation. Another important question to discuss and possibly to solve is which kind of liposuction? Which kind of liposuction we can consider as a safe surgical procedure for the treatment of the advanced lymphedema. We think that the best liposuction is not the dry liposuction for non-pitting lymphedema. According to our experience, we apply liposuction by two machine technique and always on the guide of lymph vessel sparing procedure, endorsed in green microlymphography, I mean, only after a previous proper lymphatic microsurgery. The secret for the success is to properly combine microsurgery with liposuction, with this kind of liposuction with the lymph vessel sparing procedure together for advanced lymphedema. And then, if we have the possibility to treat lymphedema as lymphedema staging a basic role for the satisfactory long-lasting treatment of lymphedema, and when? According to our long experience, we think that the best timing for lymphedema is the early stage lymphedema, but non-responding to a proper conservative treatment. That's why we consider it very important to combine always better and better, combine conservative therapies with surgical treatment, and because if physiotherapy, conservative treatment, the congestive physiotherapy can be considered as a procedure, therapeutic procedures of very important role, but before surgery, often this kind of treatment often as a palliative role, not definitive. That's why only after a proper and targeted surgical treatment, the congestive physiotherapy can become curative. Before surgery, palliative. After surgery, after proper surgical treatment, curative. That's why for the future, I think that the basis of the success for long-lasting, effective treatment of lymphedema is to discover this kind of very good combination between conservative and surgical treatment, not alone and not against, but together.
Dr. Campisi, that's well said. And, you know, I'm curious to see what the poll says, because we asked some of that question. So let's pull up the poll. So 34% said complete or complex decongestive therapy. 8% said lymphatic surgery and microsurgery, and 58% A and B, both, based on the individual condition. So I think your point is well taken. So thank you.
I can realize that can I see once again this
poll question? Let's pull it up again.
Yeah. Can I see complex decongestive treatment 34%, and then if complex decongestive treatment is only 34%, the rest is to define. Lymphatic surgery, microsurgery alone, I totally agree, not only, but the complex decongestive treatment together with the proper lymphatic surgery and microsurgery can reach the 90% of, I think, because considering my long experience, our long experience in Genoa Center, we started in 1973. Today we have this possibility, but the problem is the social conditions of patients. The problem is the level of the health organization in every country. The problem is to improve the knowledge and the consideration of the problem of lymphedema in World Health Organization. And in every politic sanitary welfare of every country. This is our problem. But another important problem is to address a lot of young surgeons, young researchers and young surgeons to acquire this kind of knowledge and training and experience and practice of lymphatic surgery. I think we have a lot of way to do.
Yeah. So Dr. Campisi, that's so correct. I would like for you to stay on. We're going to have more questions and answers later, but I'm going to introduce our final or last speaker for the day. So thank you. So now I want to introduce you to Suzanne Butcher. She's been working in the healthcare industry for over 18 years. She is in the treatment and management of patients with edema associated with lymphedema, lipedema, and vascular disorders. She spends a lot of time networking, educating the medical health professionals. She is involved in advocacy work with the Cancer Council in Australia and local members of the Parliament. She is a member of the Australasian Lymphology Association, and she holds a position on the accreditation committee of the Australasian Lymphology Association, while completing a second term as the board of director. Sue brings a lot of excellent information to us. She is a clinical manager for the Edema Institute in Melbourne, Australia, treating edema-associated conditions. She is highly specialized, and what they do is they inform patients on treatments, research, and also discuss products. She is committed into making a difference in the lives of those patients with lymphedema and lipedema. So I do want to introduce you, and Susan, thank you so much for being part of this webinar.
Thank you, Frank, for the lovely presentation. As we know, lymphedema can occur from many different health conditions. This education video talks about and demonstrates the application of the Sigvaris Compreflex reduced wrap on a patient with a difficult shaped leg. I believe this garment will change the way we treat and manage these types of limbs, achieving better outcomes for our patients.
Hi, my name's Susan Butcher and I'm a lymphedema therapist. My main role has been to come down and start up an institute which we've called the Edema Institute, and this will be for the treatment and management and education of patients and health professionals. I suppose the first signs that you would notice would be that if you went to a GP would just be the persistent edema that's just not settling. If it doesn't settle down of an evening when you go to bed and you're still getting up in the morning and that edema is still present, then there's probably a signal or a sign that's saying that there's something more that's going on, which could be a vascular issue. So the venous system's just not working properly. And this then would prompt a surgeon or a GP to send off for more tests or more observation. So some of those tests, which would be lentigraphy or just scans, Dopplers, would in the case of, say, a podiatrist or a surgeon that's dealing with veins. Another area where we can have the edema issues or develop into lymphedema mightn't necessarily be in cancer-related where they've taken lymph nodes. It could be the form of the chemotherapy and the radiation. So the percentages of lymphedema developing increases with the capacity of if nodes have been removed, if chemotherapy has been done and radiation have been done, that puts us at the highest risk of developing lymphedema. For patients, their first point of call is usually their GP. And from that perspective, then they either get that referral base then to a surgeon if it's needed, if it's a vascular issue, but also a part of that team and that support network is us as lymphedema therapists. And at the institute, where we will have the Edema Institute based in Clayton, that support network is very strongly linked to the role that the surgeons and the GPs will play, but the outcomes should be all about the patient's best outcome. With the patient that we're seeing today, she's in her mid-70s, and a little bit about her history is that she's had, in 2007, she had 3 leaky heart valves. The surgeons aren't concerned at this stage, they're just monitoring the valves in the heart, and she's on heart medication for that. In 2017, we had the gallbladder removed, and in 2018, we had the right knee replaced. So when I spoke with her prior to doing the demonstration today, she felt most of the problems that she's having sort of started mainly in 2016. She had a burning sensation in the lower part of her leg, and she was starting to lose a little bit of her mobility. So on visiting her GP, he suspected she had cellulitis infection and was treated with antibiotics. That didn't really improve. The cellulitis settled down, but she still had the pain and the heaviness in the legs. So she was referred off then to a specialist who then done scans and found that she had 2 smallish veins in the lower leg, 1 in each leg apparently. So laser treatment was still done very shortly afterwards. She was then, after her laser surgery, was fitted with medical compression below knee stockings of 30 to 40 millimetres of mercury. With that point, she then wasn't fitted again with stockings until later in 2018. Recommendations usually suggest that stockings, medical compression stockings, are fitted every 6 months. In past patients that we've fitted into the Compreflex wrap, we've seen quite rapid results quite quickly. With some patients that we've fitted into, especially a below knee, before we've gone into the knee and the thigh, we can actually have a reduction while we're actually putting the garments on. So within a space of half an hour, we can see that we need to tighten up a below knee wrap. So that's how quick that we can actually get results with these garments. But most patients would see an outcome within 24 to 48 hours, as long as they're compliant and they are actually wearing the whole garment. Traditionally, we found that lymphedema therapists used short stretch bandaging. It's costly because we have to replace the bandage, and obviously we're looking at a reduction. So when we put the bandaging on, the limb is reducing, and then we've got slippage with the bandage. So it wasn't a cost-effective way of producing this. So then when Sigvaris came up with the Compreflex reduced wrap, this just ticked all the boxes in the sense that it's doing everything the same as what bandaging would do, but just more ease for people to be able to use, and cost affordable as well. I think basically this gives the patient a sense of being more in control. They're able to be more active. The appearance-wise, without wearing the bulky bandaging that comes with it, the heat that comes with it, and just the flexibility, and that the patient then has got control over their own condition.
Today we are going to be measuring Margaret up for our Compreflex Reduce. We'll be putting her into a boot, a calf, a knee and a thigh piece. Placing the tape measure underneath the feet, coming across the head of the metatarsus, and you're just taking the tape measure at skin tension. Now I'm going to measure the eye measurement. You make sure the patient's foot stays firmly planted on the ground, sliding the tape slightly underneath and coming up and straight through. For the length of the foot, a handy tip is to have a pen at the base of the heel, placing your tape measure 0 at the base of the heel, and you're taking the measurement to the head of the metatarsus. Now we're going to start measuring for the calf piece. First of all, we need to find the malleolus, and you're working on the lateral side here, and you put a mark. You then need to come up the leg and find where the head fibula is. Those are both your 0 points. From there, you then measure up 5 centimetres, and then your next measuring point is at 25 centimetres. We're then going to take the circumference of both of those points. And again, you're doing this just at skin tension. Now we have our 2 0 points. We put the 0 of the tape measure at the malleolus and the top of the tape measure at the head of the fibula, and that gives you your G point, which is your length. For the knee piece, you're taking your fibula head point that you've made when you did the calf piece, and you come down 5 centimetres, and this is always on the lateral outside that we measure. For the knee, we've found the patella point. We've put a mark, a 0, and we have come up 5 centimetres and put a mark. Now we need to do the circumferences at those points. Again, skin tension. Now we're going to find the measuring points for the Compreflex thigh. Finding the top of the patella, we place a mark. Our next point is at the gluteal fold. Sometimes on larger patients, this can be a little tricky. By putting a tape through the groin and coming around, that will give you the opportunity to mark in the correct position.
With these leg shape, we mentioned in 2016 that Margaret was put into below knee compression stockings, and then again in 2018. You can see here at this level below the knee, I believe, the shape that the stockings have formed in this area. So we have quite a different shape happening at the below knee to what we've got happening above the thigh. Even though Margaret was diagnosed with lymphedema earlier on after her cellulitis infection, I believe there is a degree of lipedema as well in this tissue. And that's giving the reason here for, in the centre here, we don't have any space. We've got quite thickening here, which means Margaret then would be changing her posture to walk, because this area here would be rubbing against the two inner thighs. The knee area here is completely blown out. That could be because of the below knee stocking, and because we've got this component of lipedema in the limbs as well, that is forcing a lot of that fat up into the knee area, causing this lobule formation here in front of the knee. If you just turn for me around to the back now, Margaret, we can see here the definite different shapes that we've got here. We've definitely got a lymphedema component in this leg, but we've also got the areas of inflammation, and that would be possibly coming from that venous return flow and that component for why after the surgery. Also with this in the right leg, we've got it's pronating here, and you can see where the tissue is collapsing through the arch down here and starting to form that shape there. Now the reason we've gone with the reduced wrap here is because if we put Margaret into a compression stocking, the shape that we've formed here throughout the whole limb area is just too vast. So by putting her into a Compreflex reduced wrap, we aim that we can then, as Kim has demonstrated, we're able to measure individually each lower limb, knee, thigh, and put a wrap on that's going to accommodate every part of the limb. And this is one of the great advantages, especially with the reduced wrap, is being able to accommodate all the different sizes, where a medical compression stocking would not be as successful.
Now we have our reduced components to the pack here. We have our calf piece, 2 sets of liners, the spine for our calf piece, our extra Velcro tabs, our pegs, our marking pen, and our tension tabs. Now what I'm going to do is undo the reduced calf wrap, and I'm going to pop this now onto Margaret's leg to start the production of cutting it down to size. Placing the wrap around the patient's leg, getting our pegs, pegging the garment into place. Then, with our marking pen, we start to mark the shape that we want the garment cut into. It's easier to come back a second time and cut more than it is the first time. Now that we have the garment back up on the table, we join the dots and place one piece of fabric onto the other, and we make it into the shape of the calf. We then get our scissors and cut the fabric. Now we take our spine and we unzip the spine, and we place the spine onto the outer edge of the garment, always starting with the bottom of the zip at the base. Then you flip the garment over and you place the other spine. Now we turn it over and we do the zipper up. And for the top piece here, you can either use one of your small Velcro tabs, or you can use your larger piece and you just put it on to where it needs to be at the top, and you can cut it accordingly. With this one, I'm just going to use the smaller one to start with. Now we have the garment cut to size, we put the liner onto the patient's leg, place the wrap over the liner. We are now going to start at the bottom and wind the tabs around to the relaxed position. We're not putting any tension on the tabs at all. Now what we're going to do is we're going to place the tension tabs as we have the straps in the relaxed position. At the end of every strap, we will place a tension tab. These are colour-coded, which is good for the patients, because then the therapist can actually tell the patient where to pull the tabs to. And now we start pulling the tension, pulling the straps to our tension points.
We now have the thigh, the knee, the calf and the foot already in place. We just need to focus a little bit on this lobule here, which is the main reason too that we're using the reduced wrap. Kim's done an amazing job just putting all this on, and already it's had a significant lift in the lobule area. But what we can do as therapists, this becomes with the knee piece, and what we do here, we sort of focus at the lower end of the lobule, and what we're actually trying to do here is we can attach that back, and what we're trying to do is actually put a little bit of pressure in there and give that a lift up through here. And remember I said with our offcuts, Kim was saying don't throw anything away. We've actually even got larger support here if we wanted it just through this area here. So once again, we've got the tabs connected there. We put the bottom pieces on, and then we can actually put a little bit of pressure through this area up through there to give that a further lift through there. And then we've got a more uniform shape. But obviously as this reduces, then Margaret has to continue this, but we hope in after a period of time that the lobule will decrease and she'll be able to just wear the garments. Thank you very much for watching this educational video. I hope the content or the demonstration that we've presented today was helpful, and if you have any questions, please feel free to reach out.
So great presentation. So thank you, Susan, for putting that together for us.
You're welcome.
Let's go ahead and take the next polling question.
Can we see the poll questions, please? So the question is, during the acute phase of complex decongestive treatment, short stretch bandages is considered the gold standard for compression. Instead of this gold standard compression, would you consider an alternative type of compression in the acute phase of CDT? The choices are no, there's no alternative option, or no, there's no need for compression, yes, compression wraps, or yes, but only if there's more available evidence.
So while we wait for the poll, Susan, I want to get back to you. Since I met you, you mentioned that wraps are cost-effective and safe. Can you elaborate on that?
Well, they work in the same principle as a short stretch bandaging process. I think that it's probably more accurate though, because with the tabs, you can put the straps over to the tabs, which makes it more accurate, where in short stretch bandaging, the accuracy is only in the therapist applying the bandage, but also we have found now that the bandaging process has a limited time of that compression being on the limb. So at 40 millimeters of mercury, you might only have 2 or 3 hours of actually effective compression. So that's where the wraps are actually got a bit more of an advantage over, because you're just adjusting the straps to meet the tabs, so you can constantly regulate that pressure.
Can I make a contribution?
Yes, Dr. Borman, actually, you were coming up. Great time.
Yeah, okay. Thank you for the nice presentation to Susan Butcher. These micro devices are very popular in the last few years, also in Turkey. They have many, many advantages. First of all, they are cost effective in that way. For example, the patients cannot come to the CDT sessions in the outpatient or inpatient clinics, but we can teach them. It's very easy to learn and to perform. We can teach the patients or to their families, and they can do these devices at home, and also with self messages, all complete self-management techniques also achieve better outcomes for most of the patients. Secondly, geriatric patients or elderly people cannot do their self-management in the second phase of the CDT all through their life. You know, after the CDT, at least once a week, or in the beginning twice a week, they have to bandage, especially in the lower extremities, self-bandage, or their families should do it. But most of the families do not want to perform by themselves. Therefore, we suggest them these retro devices, and it brings very easiness and very comfortable, and they can themselves manage the pressures, and it doesn't slip, as Susan has mentioned, in the active phase. And we have made a study with some of the micro devices and get similar results on volume reduction with conventional bandages, and also they were more comfortable and increased the quality of life more than the conventional bandages in our study, which will appear in Lymphatic Research and Bio very soon.
Dr. Borman, thank you for that. I'm glad you commented on it. Susan, as I was watching the videos, I kept thinking of patients that I could use that on because of the difficulty with short stretch bandages. But let's get Andrea. Andrea, oh, Dr. Campisi, you want to say something? Let's unmute yourself first. So unmute yourself. If you look at the bottom of your screen, you have to unmute so we can hear you. You see on the bottom left. Yeah. There's a little microphone on the lower left. If you wiggle your mouse, you'll see it. There you are.
Okay. I would like to do a very short comment for the last presentation. Very interesting and innovative.
Thank you.
I would like to underline the social economic problems of many patients. That's why it is very important that these new devices supporting patients affected by serious lymphedema, 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 and so on, to have a support by the political government. There is a possibility to realize a sort of task force, just to induce the political governments to acquire these devices for patients on economic difficulty. I think that this is a very important problem for the patients.
Yes, absolutely.
Yes. And it seems like we face that not just in your part of the country, but throughout the world.
Yeah.
So Sylvain, let's go ahead and see what the poll was.
Yes.
The results. So 2% said there's no alternative option. 2% said no need for compression. A staggering 67% said yes, there's a place for compression wraps. And then 28% said yes, if there's more evidence. And I don't know, I'm sorry, we lost, there's Andrea. So we do have a couple minutes to talk about, you know, how does—
Apologies.
Thank you. I know it's 2 o'clock in the morning over there, so I want to make sure you didn't pass out. But after you unmute yourself, tell us briefly the evidence. How does the compression of this wrap compare to short stretch bandages?
So there's been some publications that have compared how bandages have compared to wraps. And so, for example, there's a publication by Andrea and colleagues in 2013, and they looked at wraps versus compression bandaging, and they found that the interface pressure was maintained better with wraps. And that does make sense because with standard compression bandages, as Dr. Borman said, that they loosen off as patients wear them throughout the day. And so with wraps, it's very easy for patients to be able to then self-adjust, which helps them then maintain that pressure.
Well, thank you, Andrea. There's a question that came in, and Dr. Liu, I'm going to address that to you. Somebody's asking, how about the treatment of filariasis lymphedema? And if you can unmute yourself first, we'll be able to answer that.
There are no filariasis lymphedema in China now. It's limited. We don't have such patients. But 15 years ago, yes, we have many, millions. But now it's limited. We don't have new patients. This kind of infection, no.
So with the patients that have filariasis, is the treatment any different? We're talking about surgery, we're talking about CDT.
I'm sorry, in my, when I started my work, there are no such patients in our country.
Okay.
Our patients are limited, this kind of disease are limited in China. We don't have new patients. So I don't have the experience for the treatment of this kind of patients.
Okay. Anybody else in the panel want to take this question? Thank you, Dr. Liu. And that's great.
I can make a contribution if you have time. Actually, I have been in India. We don't have filariasis in Turkey, but I have been in India, and so that they apply the same CDT techniques. But as there are lots of patients, many patients, they generally teach the management, self-management techniques to their patients, and they follow them with follow-up visits. But the CDT procedures are still available there, and they have good results, especially with compressive techniques that I have seen in India. But I think that CDT is the same both in filariasis or other lymphedema causes. They are the same, but according to the number of patients in India, they commonly do not perform MLD. They prefer self-MLD. They teach and educate patients, and they teach them the compressive bandages, compressive bandage techniques, multi-layer bandaging, and then they follow up their patients by these ways.
Okay, thank you. Susan, Dr. Campisi?
Yeah.
Go ahead.
There is a very curious contradiction in the economic reality of China and India, because we know that China and India have a very important economic power all over the world. That's why my question is, all the community, scientific community, and all together, we have to press Chinese and Indian government to help the people affected by lymphedema, because the patient have no economic power, but the government and all the firms and the economic society and so on have very big economic power, and then they can offer a percentage of their money to help the people affected by elephantiasis, above all in China and in India, above all. And I think we have to develop a great enthusiasm and trust for this target, very important target for our scientific community. What do you think about Ningfei? What do you think?
Please listen to me. Can I speak a few words on your comments? I think the situation in China and India are different. We don't have filariasis infection in China now. All the patients, it's 50 years ago, we have millions, but under the government control, the chemotherapy for such a patients are carried on in the whole country. So we don't have such a patients in our country now. We don't have. The situation in China is the same as in Italy. Most of patients with lymphedema is secondary lymphedema of the tumor cancer treatment, not filariasis. It's different.
In China, the same than in Italy? I don't know.
I think the same.
I don't know.
We don't have the filariasis lymphedema in China now. 50 years and 60 years ago, yes, this is the situation. But after the 1950s, the patients take the drugs, they disappeared. They controlled, limited. The WHO gave the letter to our government that they said the filariasis in China are disappeared. You did the work. So this is not a situation in China, as in India, as in South America. It's different. We have the patients, most of the patients are secondary lymphedema due to the cancer treatment. I think the same as in Europe. This is the situation.
We have to change this situation. We have to improve.
Yes. And I agree. And Dr. Liu.
All the world, all the lymphologists are fighting against the secondary lymphedema due to the cancer treatment.
That's why.
Italy as in China. We don't have flares. It's different between the China and the India. It's different. We don't have any more.
Okay. Well,
that's
why
I congratulate the Sigvaris team and the organizers to have organized this webinar, because there are many aspects, many problems, and to solve for lymphedema patients, and we have you give in this sense a very important contribution to solve this very important problem on the social economic point of view of our patients.
Yes,
thank you very much. Thank you.
Thank you too.
And before I turn it over to Sylvain, I want to thank you, Dr. Liu, for sharing your expertise, Dr. Campisi, Dr. Borman, Andrea, Susan. Thank you for participating. Great information. Of course, there's so much more we can talk. Sylvain and Sigvaris Group, thank you for sponsoring this. And then also keep in mind that this is being recorded for people to watch later. And if we didn't get to your questions, Sylvain, we're going to pass that along later. So thank you. And have a great day.
Thank you.
Thank you so much, Frank, for moderating the event. And we are really looking forward for next events in 2021 that will come up. And thank you so much for participating and making such a great job with the presentations, and also for the expert panel. It is really always a great pleasure to have you on board, and we are looking forward to work together also next year. Have a nice vacations, also Christmas vacations, and talk to you soon. Thank you very much.
Have a nice year to all. Have a
bye. Thank you.
Bye. Thank you.
Goodbye.
Goodbye.